they're relatively straightforward because they're named after the bones that they live in. So there are 4 pairs of paranasal sinuses: maxillary, frontal, ethmoid, and sphenoid. And as I say, they're named after the sinuses that they reside in. On the coronal CT on the left-hand side, we can clearly see the maxillary sinuses here, and also some ethmoid air cells. And the ethmoid air cells sit between the orbits. Again, on the axial images, we can see the ethmoid air cells. And there are a number of these. They're called ethmoid labyrinth. And the ethmoid labyrinth sits between the orbits. And at the back, you can also see the sphenoid air cells, which sit within the sphenoid bone. And then on the sagittal CT, we can appreciate the frontal air cell in the frontal bone, anterior and posterior ethmoid air cells within the ethmoid complex, and the sphenoid air cell at the back, above which is the pituitary fossa, which sits in the sella turcica here. So CT is the modality that we usually use to look at the paranasal sinuses because it really shows us a lot of really good bony anatomy. But when we're born, we don't have all our paranasal sinuses. So at birth, we normally have ethmoid air cells, and about 50% of us will also have maxillary sinuses. But at the age of 1, here you can see that there's some opacified ethmoid air cells in a 1-year-old and small opacified maxillary antera as well. But as yet, their frontal and sphenoid sinuses have not developed, and these usually start between the age of 1 and 2 years. Now, in some people, they never develop. So the rule is that the later the sinus is in the developmental process, so that's the latest ones are the frontal and the sphenoid air cells, the more likely they are to be absent. So in this patient, you can see that on the images, there are no frontal air cells. And this is a congenital, developmental anomaly, really, where they don't have any frontal sinuses, they just haven't developed. And in this patient here, you can see that there's nothing on the right side, but on the left, there's a small frontal air cell called a hypoplastic frontal sinus. Sometimes the sphenoid sinuses are absent, as in this patient here on the axial and coronal CT images. You can see that there are no sphenoid air cells of note within this sphenoid bone here. And in this patient, something has happened called arrested pneumatisation. So we've had a go at pneumatising the sphenoid, and there is some air within an air cell there. But then there's this hypodense area, which looks a bit like a sort of chondroid matrix. And people do mistake this for pathology, but just be aware that sometimes the sphenoid does not pneumatise fully, and you can get this rather unusual, a slightly rarefied looking bone within the sphenoid, which represents arrested pneumatisation, and it's not pathology. Here it is magnified up. Now, it's also important to know the difference between a small sinus, a small normal sinus, and a small abnormal sinus. So in this case here, we've got coronal and axial CT image, and the left maxillary sinus looks quite normal, as you can see here and here, but the right side is small. Now, if we look carefully, we can see that the ostium, which is where the air can get in and out, so the drainage pathway for the sinus, is patent. And this bit of bone here is called the uncinate process. So the ostium is open, so this is a normally aerated sinus. And you can see here that this looks like diploic cancellous bone, which just hasn't become pneumatized. So this is a hypoplastic sinus. Compare that with this, where again, a normal looking left side, but an opacified small right side. In this case, the uncinate process is now here, abutting the floor of the orbit, and the ostium is blocked. So remember, this one, the ostium was open, and this one, the ostium is occluded. Because it can't drain, the sinus is now opacified, and it gets smaller over time in this condition called silent sinus. Not only that, but the floor of the orbit comes down as the sinus gets smaller, and you get enophthalmos because the orbital volume increases. So just to remember that not all small sinuses are small because they are developmentally small or hypoplastic. Some of them are pathological. If we look into the nasal cavity, we can see these little bones called turbinates or concha head-on. There are 3 of them. Dividing the cavity is the nasal septum, And on either side, there's an inferior, a middle, and a superior turbinate or concha. And below each of these is a meatus, inferior, middle, and superior. If we look at the turbinates side-on, you can also see that they lie in a line on the side wall of the nose, inferior, middle, and superior turbinate, and below them, inferior, middle, and superior meati. But you can now see that there's a gap between the roof of the nasal cavity and the superior turbinate, and this is called the sphenoethmoidal recess. So everybody wants to have something named after them, don't they? So I'm going to have a go now at Loney's law, and that says the more anterior the structure is, the lower it drains. So welcome to my long-suffering husband, who often has to have photographs taken of him and then bits of CT scans superimposed on him to block him out. So here we will look in a bit more detail at the CT scan. What you can see here is that the most anterior structure on the face is the nasolacrimal duct, and that therefore drains the lowest. So the law states the more anterior it is, the lower it drains. So the anterior bit, which is the nasolacrimal duct, goes into the inferior meatus. Next back in a line, the frontal sinus, anterior ethmoid sinuses, and if you think about what's lateral to these, the maxillary sinus. All of these drain into the middle meatus. Next back, posterior ethmoid, they drain into the superior meatus. And then furthest back, the sphenoid sinus, that goes into the sphenoethmoidal recess. So this is a little tip I learned over the years, wish I'd known it earlier. How do you tell the difference between an anterior and a posterior ethmoid air cell? No, it's not a joke, it's real. So if I showed you this coronal CT scan, would you know whether it was an anterior, as I've written here, or a posterior ethmoid air cell? Well, the thing to look at is this, the middle turbinate. The middle turbinate has stalks which attach it to the roof of the nasal cavity, and they're called the basal lamella. If these stalks are attached at the top to the roof, so have very much an up and down look about them, then you're in anterior ethmoid territory. Further back, the middle turbinates become attached to the lateral walls of the nasal cavity, and at that point you know you're in posterior ethmoid territory. So that's a useful tip to know. Depending on what you want to look at, you need to decide which imaging planes you're going to look at. So for nasolacrimal ducts, you can see them very nicely air-filled here at the front, so they go lowest. And they are draining down into the inferior meatus, which you can see here under the inferior turbinate, and the nasolacrimal ducts in this patient contain air. Next back is the frontal sinus, and you can see here it draining down into the middle meatus. And the best planes for looking at this are sagittal and coronal. If you want to look at the maxillary ostia and the ethmoid infundibula, the best plane is the coronal plane, where you can appreciate these structures and also the little bit of bone that I talked about called the uncinate process. For the sphenoid sinuses, the best plane is the axial plane, where you can see the sinuses draining into the sphenoethmoidal recess. Now let's talk for a moment about the osteomeatal complex. We need to remind ourselves of a few structures. Firstly, the middle turbinate. Secondly, the uncinate process. Lateral to the uncinate process is the maxillary ostium. That's the draining pathway for the maxillary sinus. And between the uncinate process and that big air cell there called the ethmoid bulla, which we'll come on to in a minute, that is the ethmoid infundibulum, the drainage pathway for the anterior ethmoid air cells. And here, between the tip of the uncinate process and the ethmoid bulla, lies a little semicircular gap called the hiatus semilunaris. And that's where the maxillary ostium and the ethmoid infundibulum drain into. Here you can also appreciate the frontal recess, which is where the frontal sinus drains into. And between them all here is the osteomeatal complex. And the point of many surgical operations in the sinuses is to open up the osteomeatal complex to allow these sinuses to drain better. So the object of most of our reporting of sinus CT is it's not about snot. It isn't really about the sinuses which are opacified. It's about the drainage pathways and the normal variants which might obstruct them. So why do we need to know about normal variants? Well, firstly, they can impair drainage, they alter anatomy, they can put things at risk during surgery, and if you don't tell the surgeon about them, you might be telling the lawyer about them later. So remember. Accessory air cells are often ethmoid air cells. This is the ethmoid labyrinth on both sides, and these greedy ethmoid air cells can extend in all directions. So the Agonasi cell here, the Agonasi means nasal mound, so aga meaning mound. And the Agonasi cell is the most anterior ethmoid air cell, and it sits by the side of the lacrimal bone. And as you can appreciate here, it's sitting right next to the middle turbinate, and it can narrow the frontal recess if it's large. The largest ethmoid air cells are called the Ethmoid Bulla. You can see one here. They usually sit above the ethmoid infundibulum, and they are on the medial aspect of the orbit, and they are the largest air cells. And again, if they get very large, they can push the oxygenate process down and narrow the osteomeatal complex. Halo cells are also called infraorbital ethmoid air cells. In this case, the ethmoid air cells have tried to go greedily under the orbit. You can see them extending on both sides here. And again, these air cells can narrow the maxillary ostium and the ethmoid infundibulum, and you might need to remove them in order to open up the drainage pathways. Sometimes posterior ethmoid air cells also have a go at encroaching on the maxillary sinuses, and you might see this appearance here. If the anterior ethmoid air cells decide to go up into the frontal sinuses, they might form frontal air cells, types 1, 2, and 3, depending on how high into the frontal sinus they get, or supraorbital air cells. The difference being that with frontal air cells, they lie in front of the frontal recess, whereas supraorbital air cells lie behind the frontal recess. That's the difference. Easiest to see on sagittal CT. Onodi cells are greedy posterior ethmoid air cells encroaching on the sphenoid sinus, and here we have a couple. On this side, the air cell is also extending into the anterior clinoid process. And it's important to tell the surgeons about that, because just above there sits the optic nerve in the optic canal. So if they pop an endoscope into that air cell, thinking that they're in the sphenoid sinus and have a route around, they could possibly avulse the optic nerve. You can also see here something called the lateral recess of the sphenoid sinus. It's an outpouching of the sinus that extends between these two round dots here. Above and lateral is the foramen rotundum for the maxillary division of the trigeminal nerve, and below and medial is the Vidian canal, which is making its way to the pterygopalatine fossa. Sometimes these Vidian canals live on little stalks that protrude up into the sphenoid sinus, and they look a little bit like snails, don't they, protruding here. And you can imagine that somebody with an endoscope could quite easily go in and pull those out. Middle turbinates can also get pneumatized. So here we have a large pneumatized middle turbinate. This is called a concha bullosa, an air cell in the concha. If the basal lamella is pneumatized and not the blobby bit on the bottom, this is called a lamella concha. So that's two different types of middle turbinate pneumatization. Here you can see bilateral middle turbinate concha bullosa. And in this one on the left side, you can see that there is also soft tissue, and sometimes they can be affected by chronic inflammatory change and become hyperostotic. Sometimes they can even have fluid levels in them. This is the normal direction for a turbinate, curling outwards. This is an abnormal direction. This is called a paradoxical middle turbinate when it's bending the wrong way. And again, you can imagine that this bulge can push the uncinate process laterally and narrow the ostium. And sometimes you need to remove this part of the middle turbinate and open up the osteomeatal complex during surgery. The The nasal septum is very rarely straight. So in this patient and the second patient, you can see them both deviating to the left and pushing the inferior turbinate over and causing significant narrowing of the left side of the nasal cavity. In this patient, there's a large defect in the nasal septum here. You can also see the defect in the cartilaginous part of the septum here. So not only do you need to look and see which direction the septum is pointing in, but also whether it is intact or not. Occasionally, the carotid canal can protrude into the sphenoid sinus, as it does in this patient. In this case, there is an intact, thin, bony covering, but sometimes the canal can be dehiscent and the artery can be in the sinus itself, in which case the surgeon always wants to know. In this example, there is pneumatisation of the anterior clinoid, which has completely encircled the optic canal. And you can imagine that this optic nerve is now very vulnerable during surgery to potential avulsion. Here we have some dental roots poking into the maxillary sinus, and this is a very common normal variant and usually of no significance. Completely different from this appearance here, where we can see a little dental root poking into the maxillary sinus, but there is lucency around it because there is a periapical cyst. Periapical infection has caused widening of this periodontal space, and if there are tiny gaps in the bone around that cyst, you can call them fenestrations, and they may lead to infections around the roots of teeth going into the sinus and causing odontogenic sinusitis. So here we can see the roof of the nasal cavity, and it's formed here by the cribriform plate. And the cribriform plate should sit either halfway down the orbit or above that level. If it's lower, you need to say it's low-lying because the surgeon's more likely to hit it with an endoscope during surgery. On both sides here are the lateral lamella and their direct continuity of the middle turbinate basal lamella, which you can see here. And you can see the basal lamella. And these are the fovea ethmoidalis. And as you could see, it would be possible to measure the distance between the fovea and the cribriform plate, that is the length of the lamella. And of course we can do that, and we can classify these according to Kairos. Now in this patient, the lamella are very horizontally orientated, and this measures between 1 and 3 millimeters, making it a Kairos 1. In this case, there's shallow olfactory fossa between 4 and 7 millimeters, Kairos 2, and in this patient, a borderline 3, just over 7 millimeters in depth. Some people also classify type 4, where there's asymmetry of the fovea. I think that's very common. Most patients would probably be classified type 4 if you use that. You can also, of course, see sinuses on MRI. And here you can see pre-contrast and post-contrast T1 imaging, and just how avidly the mucosa lining the turbinate enhances. And you can see very nicely the maxillary ostia, the osteomeatal complex coming into here, the ethmoid infundibulum. Of course, the bones are easier to see on CT, but if you have any concern regarding tumours in the nasal cavity, then MRI is a very useful adjunct.